Drbeen.com. Welcome to one more show. So with us today is Dr. Keith Berkowitz. He is, as you would see, an internal medicine board certified physician in New York. In addition to that, he is a member of a beautiful number of societies. We'll talk about that as well. And he is a part of FLCCC as well. In the past, he has worked with Dr. Atkins. In the past, he has worked a lot on HIV, and nowadays he's working a lot on long COVID. So, Dr. Berkowitz, welcome.
Thank you so much for having me. I really appreciate it.
You're very welcome, and you are a very, very cool bean. So, tell us a little bit about your daily routine and your work.
So, my background, as you said, is internal medicine. I kind of consider myself, I call it an integrative physician, where I take the best of both worlds, both the holistic world and what we call the conventional medical world, and try and combine that in a treatment program. And for years, we've actually looked at that. I've treated things from chronic fatigue syndrome, looking at Lyme disease, and now that's really progressed as we've gone through COVID to what we call COVID long haul syndrome, which is fascinating and shares some of the same characteristics that we saw in these other disorders.
Got it. Thank you very much. So let's start from a little earlier from your career. We'll go to HIV in a second. First, tell me, you have worked with Dr. Atkins, right?
Yes. You're actually now today, you're allowed to say that, by the way.
Okay. There used to be a time when you would.
I'm going to tell you a funny story. So when I first got introduced to Dr. Atkins in 1999, he was very controversial at the time. We actually, he submitted a paper to present to the American Dietetic Association on low carb diets. And he actually got rejected. They wouldn't let him present. And it wasn't until this major article that was published in New York Times Magazine by Gary Taubes that he started to get accepted for his views on, that sugar was problematic, that fat was healthier, and that we needed to cut sugar out of our diet in order to be healthier today. And what was interesting about that, and I got to learn from him, is the importance of vitamin C.
So talking about sugar, you would see that a lot of people would leave comments even with this video to say that this all is a hoax, to say that blood sugar or the sugar or carbohydrates have anything to do with anything with the high blood sugar. It's really the plant-based diet that is important and nothing else. So tell me this, when you were working with Dr. Atkins, what was the reason that he took that path, and how much do you feel that hyperglycemia is, and I'm going to put you on the spot, so please.
It's okay. I don't mind.
Because you're going to get some heat as well. What do you think? What are your views and learnings?
So the funny part about Dr. Atkins, you would think he would have taken this concept from, out of, the air, but he actually took it from a Journal of American Medical Association study that was done showing that sugar was bad. And what he really understood early on, it wasn't just about glucose, but it was glucose's relationship with insulin and how hyperglycemia or high glucose levels led to high insulin levels. And I think we've learned through today, one of the biggest villains in medicine today is actually insulin. High insulin levels lead to obesity, lead to cancer, lead to heart disease. And actually, even in COVID, we see much poorer outcomes in people with high insulin levels that are diabetic or even pre-diabetic. And for one reason that happens is these individuals tend to develop issues like fatty liver and difficulty, and more likely to get vascular problems as well.
Got it. Thank you very much for this. I would drill down more a little later about this as well. I want to ask you about your work with the FLCCC. Can you tell us a little bit about that?
So it was really interesting beginning. So I remember this so clearly. So it was in March. I had learned about vitamin C because I had been using it for years in my practice. We used it for immune purposes. And I was thinking to myself, wait, there's got to be a role in vitamin C in COVID, right? And I started looking, and I found all these great articles by Dr. Paul Marik showing how he used vitamin C in sepsis. And I'm like, oh, wait a second. COVID must be sepsis, right? Sepsis is usually caused by an infection, viral or bacterial. They end up in the intensive care unit. Wait, this is COVID. So then I ended up speaking to Paul Marik, and I said, can you verify this data? Do you have any other physicians I can talk to? Then I got to meet Pierre Corey, Joe Verone, Jose Iglesias, Umberto Meduri, and with the help of Howard Kornfeld and also Fred Waschkau, we actually ended up forming the FLCCC, and that was in March of 2020.
Got it. So one thing that is interesting for me in the context of FLCCC or in context of COVID and trying to manage this is the amount of and the intensity and the emotion involved in countering or suppressing or snubbing anyone who may talk anything other than the vaccines. My question to you, have you experienced any such thing? Have somebody said, hey, don't talk about ivermectin or fluvoxamine or other things? What has your experience been? You're working in New York.
So I feel like this is my third time around with this, actually. I remember in HIV, there was a big controversy about using, we talked about this off the air, Bactrim, which is a very safe antibiotic, which was used for prophylaxis against PCP pneumonia, which was a common, opportunistic infection with HIV. Again, I saw with Dr. Atkins using a low carbohydrate diet, and also he was using intravenous vitamin C for immune support. And I think what it is I think, and now in COVID, we now started with using actually methylprednisone, right? And vitamin C early on. That was controversial. And now steroids are kind of part of hospital care. And vitamin C in lower doses is probably part of that as well too. And then the transition to using something like ivermectin. To me, what's interesting is I've always been the big believer, try anything you can.
And that's what I want to dig more. You said that in the HIV days. So tell us when the HIV was newly discovered, it started spreading. Were you a medical student or were you a doctor?
So in mid-90s, I was a medical student at St. Vincent's Hospital in Chelsea, in the Village in New York City. And I learned medicine by the fire. I was thrown into the fire. I remember my first patient as a fourth-year medical student was this gentleman who was intubated, but they didn't have any room in the ICU. So they had intubated gentleman I was taking care of on the regular medical floor, which I probably wouldn't see today, right? That would never have happened.
Yeah.
And what's interesting is we were faced with opportunistic infections, viruses, parasites, other diseases that we didn't know what to do for. And the one that where I clearly remember and kind of looks at COVID today is PCP pneumonia, pneumocystis carinii pneumonia, which is so interesting because it was controversial in those days as well too. And if you look at a chest CAT scan of PCP pneumonia, it reminds us of something today. It has that same ground glass opacities we see now with COVID-19. And the interesting challenge in those days was doctors that I learned from at St. Vincent's were starting to use Bactrim, which is an inexpensive antibiotic. Remember, it wasn't PCP pneumonia, it was an antibiotic for bacterial infections, and steroids and corticosteroids, which was so unusual in those days to use in someone with an acute infection, right? It was not really thought of as done, but it was interesting that these patients, once they got the two treatments, they actually got a lot better. But it took a long time for people to understand that was what worked.
Very interesting. So in those days, was there similar pushback as we have today? I mean, we are supposedly advanced at that then, at least that time.
Oh, I would say definitely. The only difference, there was no social media, so no one knew what you're doing. There was no one
walking with a very important point,
Instagram, but yeah, definitely. And I remember, my mentor at the time was the doctor, really, I think more than anyone else I've ever trained with, who formed me to be, who I am today, and really explained to me that sometimes you've got to try anything. When someone's acutely ill and with a chance of dying, then you throw everything at them, including the kitchen sink. And I think that mentality really holds true today, where you really have to try whatever you can. And I think it was very hard for people because we were never really used to being taught that way. We were really taught more like from a flow sheet model, right? I don't know if you were taught the same way. You have symptom A, you treat with medicine A. If you have symptom B, you treat with medicine B. There really wasn't one where symptom A may lead to medicine C or D or E, but we're not sure. And I think it really went against the way we were trained, and it was very hard for me to understand that at the time. And it took me a while to really understand that sometimes what you see in front of you is not the way you have to treat something, that it's more complex. And sometimes you have to go what I call outside the box to find other ways to get and solve the problem.
And so this is an interesting point as well, because I always thought that when we become medical doctors and when we are taught medicine and we are taught how to think about mechanisms and how to think about diseases and symptoms and what could be underlying, and then how to think about how to manage them, we will be those free thinkers, at least within the framework. And I used to think that this algorithm based thing, this protocol based structures, and I understand that ivermectin, or sorry, the I recover is a protocol too. But there is one thing to say, here is some protocol that works versus saying that works or not, I'm going to force you to adhere to this protocol. I thought that protocols actually remove some of the thinking part of the process. And so doctor becomes more of a, here is the line items I'm going to follow. Is that, and I used to think that this is because the society is so litigious that if somebody deviates a little bit from the protocol and something happens, people are going to sue them. And so if the doctor stays within the structure of a protocol, they can take that shield and say, well, I did what it says. Is that a correct way of thinking about it, or there is more?
I kind of look at it I never thought of it that way, but I thought of it, and I kind of use this interesting kind of differentiation. Where does science and art intersect, right? So there is a science of medicine, right? Which is what we know. I always think of, I think it was Cochrane's review of infectious disease recommendations. What percentage of that was based on great evidence? I think it's like 16, right? It's like a very, very low number. And so again, so that's maybe science, but then science really morphs into art. And that's where I think is so important. What's often the nuance that's lost in medicine is that you have a problem in front of you. And one of my professors says this so great. He said, when you see the patient that looks like the textbook, let me know. I'm still waiting to find them.
Absolutely correct.
And
There
I
is
think
no
that's
patient.
and I think that's where art of medicine, where experience, anecdotal experience, is so critical and often lost, is that you learn from doing, right? You see 10 cases that look like this, and the treatment works, then you're going to adapt your treatment to that. And then if you start seeing a case that kind of deviates, you may have to adapt to that. And I think that's the nuance in medicine that's kind of lost a lot of times. And the term follow the science, that's great I think science is a great foundation, but really the practice of medicine, and my brother always says this so great. He says, when you stop practicing, get it right, I'll come see you.
Absolutely, absolutely. You're
And
very,
that's
very
where it
correct.
becomes an art. And I think that's often lost, that the actually the application of medicine is an art. The foundation, I believe, is science, but the application is art.
And application including withholding, including, I don't think that this medicine is going to work at this time. For example, remdesivir is something that should have been stopped to say it is not working, but it is continuing. So that is where we are at this time. One more thing that I found interesting nowadays is the amount of distrust by the healthcare leadership on the competence of the doctors themselves to be of thinking mind. When they force down and say, you're not going to talk about IVM, or you're not going to talk about fluvoxamine, and this is not allowed and that is not approved, even for the approved drug off-label use, there are huge suppression and snubbing. To me, that is a demonstration of, hey, we don't trust you, we do not feel that, we're not confident about your decision making. Why has that happened?
I think it
And
starts in
again,
medical
please
school.
skip any question if you like.
I think it starts in medical school, because I think there's a big difference in training. I think when you and I trained till today, I think the amount of hands-on approach that medical students get today is probably much less than we had, where we were really thrown into the fire. Like I gave you that example for my patient I had at St. Vincent's. That was my patient. I was a fourth year medical student. I was the one who presented to the attending. There was no resident or intern in between me and the attending. So I got that hands-on experience. So I learned how medications work because I had no choice. And I think if you don't have that early experience in dealing with, health in that way, I think there's a disadvantage to that. And I think it becomes more theoretical medicine, right? Rather than practical.
Yeah, I totally agree with that. And there is a huge amount of damage and lack of it seems like as a society, what we have done is we've said we will not be doing any thinking. Even the trained folks amongst us will not be allowed to do any thinking. We're going to and put that thinking mind and the responsibility of it with, let's say, big pharma, and we would let them figure it out, that what to think and how to think and how to come up with something, and then they would tell us what to do and we'll start doing it. We would just put away our thinking, and it baffles my mind that we have reached that kind of a point.
And I think, you know, what's one interesting, and I always talk to my patients about this, I think there's a confusion between being right and being successful. And I think that leads a lot to that, right? Is it really important to be right in your treatment? Probably not, right? It's more important to be successful. If the outcome is better, then everyone wins, right? Being right and not being successful doesn't give you a good outcome. And I think we've gotten a lot of confusion between those two terms, where we've placed such an importance on being right, on doing it the right way, rather than where the importance should really be is on having a successful outcome.
I totally agree with that. So I still see people attacking those who are saying that, hey, I have great success with something, and people saying, well, there is no RCT for this. Well, here is a doctor who's saying, in my community, in my practice, I'm seeing success. Let him do what he's doing. He is successful for some reason. Let him apply his medicine and his art of medicine. So I'm gonna
add one more point to that. And I think where that really fell apart is where it went from really private practice with a focus now to hospital-based medicine, right? So I think medicine really up until the 90s was more of a private practice model where people went to a doctor and the outside. Now that's really shifted much more to hospital-based model. So I think the nature of hospital-based medicine is to have more structure, to have more protocols, to have more flow sheets, where probably a practice-based model is much more free-flowing.
I agree, but for example, I'm going to give you another example with this. I totally agree with that. Someone forwarded me a letter today where an insurance company had reached out to them. They're a healthcare professional, and said that we are seeing that you are using IVM in your prescriptions. Realize that we have the right, I'm paraphrasing the letter, we have the right to come back to you and ask you for why did you prescribe it, and we can review you. And if we thought that you are prescribing it for non-indicated cases or situations, we can refer you to our fraud and abuse department. Plus, we will refer you to all the licensing and accreditation agencies as well. This is the new medicine. This is the modern medicine.
You know what's interesting about that? You know what overcomes that? The outcome. See, what I find so interesting. So if the outcome is a good outcome and a safe outcome, that overapplies everything, right? So what got you to the outcome, as long as it was done safely, I think overweighs it. So they, from that aspect, they have to prove that it was done with malfeasance and led to a bad outcome. If there was not a bad outcome, very difficult to prove an issue.
Absolutely. And this reminds me of that case where the doctor was sued that he has been using ivermectin for COVID in jail. And his response was, can you tell me if anybody died? Everybody who I was prescribing and managing, they're all safe and healthy. So what is it that I did wrong? I'm paraphrasing this part as well. So I want to switch to COVID. And Omicron is nowadays scaring us as well. News, for example, Britain just said that, hey, you know what? Holidays are once again in, we're going to shut down and we're going to be careful, and there's going to be an emergency. And so I heard Boris Johnson's speech. My question to you, number one, are you seeing patients which you suspect may be Omicron? Number one. Number two, do you have sequencing available to you? If you suspected someone may be Omicron, can you say that, hey, I need this person to be sequenced?
So it's so interesting. So part one, I'm not sure I've seen any. I think right now it's interesting. Cases are up again in New York, but actually they're mostly mild in general. So it's possible. The problem with sequencing, we don't have access to that. The public health officials are the only ones with access. So they're doing the sequencing, but we don't get feedback on individual patients. It's more feedback as a whole, saying, okay, this is what who has Delta and who has Omicron. So it's very difficult to tell what is what. I think there's been about 20 cases now in New York,
Yeah.
roughly. So again, I'm not sure the individual practitioners know if their patient had Omicron or not. They just
Got
know
it.
that there is Omicron. And I think that's one of the issues we have with medicine today, right? Because I think that's so critical. If we do see a shift in the variant, that actually makes a difference because treatment may be different at the end of the day.
Absolutely. So then tell me this. I'm going to keep switching towards COVID and then long COVID. How is your observation in your patients? Do you get similar number of COVID patients nowadays? How do you manage an acute case? I'll go to long COVID in a second. What is your frequency of patients increasing, reducing, same?
I
And how
think
are
it's
you managing?
reducing a lot. I mean, I do have my first case of reinfection, like real case of reinfection, which was enough that needed some treatment. And actually, what's interesting about them is they had very high antibody levels. So they had antibody levels of almost 2,000 using LabCorp's tests. And LabCorp uses a range from 0.8 to about greater than 2,500. So that was interesting. So that's my first real case of reinfection. I mean, could that be an Omicron case? It's possible, right? His spouse had it, not so severe, but developed it. I think as a whole, the number of cases I'm seeing has actually dropped dramatically. I think really our peak was much early in the year. March and April was a huge peak for us.
Got it. I want to quickly flash this note here. Texas Meg, who's a cool bean plus a moderator, helps a lot with John Snyder and with Schlant and with Skyfrog, with Bonk. So Texas says CMS threatened to shut down Devereaux's hospital. Congressperson intercede. UMMC can correct deficiencies now, but we know the reason. So was there something like that happening? Are you aware?
I know I saw a video with Dr. Verone and Congresswoman Sheila Jackson Lee that just talked about, and I think it's so critical because they serve that hospital such a, an at-risk community. They service a lot of the minorities, the Medicare and Medicaid patients, which really need as much service as they can get, and it's a shame. And Dr. Verone's statistics have been off the charts. His mortality rates are some of the lowest in the country when it comes to COVID.
He's competent. He's been on this show and I totally and absolutely loved it. So I'm going to quickly flash a medical disclaimer note so that when we are talking about the medical drugs and the management protocol, guys, please realize that this is not a medical advice. This is doctors talking about management with each other. You are listening in as well. And I think that is a great thing to be able to share, but don't self-medicate. Talk with your doctors for your situation. So having said that, long COVID, what are the symptoms that you're seeing? Are you seeing any difference in long COVID compared to previous patients of long COVID?
So it's interesting. A couple of new symptoms I'm seeing. I don't know if you see the same. Joint pain and swelling, but only in the hands. That's a new one I've been seeing. Brain fog has been a constant one I'm seeing. I'm seeing more tinnitus, more lightheadedness, symptoms of we call rapid heart rate is very common without a drop in blood pressure. So something we call POTS, which is postural hypotension, which I saw early on with more of a drop in blood pressure. Now I see with just normal blood pressure, but with a rise in the heart rate. Headaches, a lot. Sinus pressure I see as well.
My apologies. I was just going to very quickly say this, and my apologies to the audience as well who are listening and saw me interrupting. My apologies. We have a cool bean who had COVID recently, and he is recovered. However, he gets high blood pressure with tachycardia.
So this is what I always find interesting about high blood pressure. So whenever, and I kind of want to go aside for a second. Whenever I look at high blood pressure, I always do orthostatic changes. So high blood pressure could be also from dehydration. So high blood pressure, although typically we think of low blood pressure being associated with dehydration, high blood pressure can be as well, right? If the heart has to work harder, and is more vascularly depleted, we say blood pressure can rise as well as heart rate. So I suspect that may also be possibly symptoms of POTS, postural hypotension. And you and I have talked about this before, whether this is inflammatory syndrome whether this is just kind of a post-viral syndrome, right, where the body's depleted afterwards and just never has been brought back up to what I call baseline. Or could this...
Sorry,
go ahead.
please.
I'm sorry.
I was going to add to this, and this is, I think, going to be very important for the listeners. You had mentioned once before when speaking with me that sometimes you have long COVID patients with tachycardias who come to you and you do something, you manage them, and they become recovered. They become happy and recover. What do you do? What is your protocol?
So, it's so interesting. It's so basic. It's kind of funny, actually. I always think of when we were treating the flu, what's the first thing we do when people have the flu? We give them fluid, right?
Yeah.
So again, if someone gets hospitalized with the flu, the first treatment is intravenous fluid. So that's what I'll do with B12 and magnesium. And hopefully by restoring some of that volume back, then actually they do better. The other thing I've tried, and I do mostly at home, if they're not as severe, I'll actually do water and I'll add salt, either Himalayan salt or Celtic salt, to try and increase water absorption for them. And I think people forget a lot of times when we drink water, very little of that water actually goes intravenously, intravascularly, right into the vascular system. Whereas when you give something intravenously, you get 90% plus into that vascular system. And I think it's very important to bring what I call volume to a normal state, because if the body doesn't have a normal state of volume, it's under tremendous amount of stress. You need to remove that stress first, and often adapts by raising your heart rate, could be raising your blood pressure, lowering your blood pressure to try and compensate.
Got it. So if I am a patient of long COVID, I come and visit you and I request you to help me. What is your approach? How do you go? What are your steps? What is your magic?
It's so interesting. What I do with all patients, I actually have them fill out a questionnaire before they come in to really kind of get a good handle of your symptoms. I think what's so interesting a lot of time is that people don't realize what their symptoms are unless they're challenged with questions about their symptoms. And especially with long haul COVID, I think people feel certain things and don't realize that may be part of the same syndrome. Number two is I'll do, as I was saying, I always do blood pressure and pulse lying down, sitting, and standing to see if there is a challenge, right? If when they stand up, does the heart rate go up, or does the blood pressure drop, or does it go up? If that's normal and I still suspect what I call POTS or a tachycardia syndrome, is I walk them through the hallway. I'll take the pulse first and I'll walk them around, and if I see that the pulse really goes up very high, that's part of the problem. And then after taking a good history and stuff, I'm interested in things, for example, we talked about, you and I previously, Epstein-Barr titers. That I really believe one of the main mechanisms behind long-haul COVID is the reactivation of Epstein-Barr virus, which is an herpes virus, which most of us had when we were younger in the form of infectious mononucleosis, but then often gets reactivated, and we've seen before in chronic fatigue syndrome, and I think also in long-haul COVID. Actually, interesting enough, I had my first case this year of a 74-year-old woman with acute mononucleosis. And which is so unusual. I actually asked her husband who she was kissing. I'm like, your wife. And it's interesting. It's very unusual because this is typically a disease of people in their teens and 20s that we don't see in acute form in much older people.
Very, very accurate. I actually saw a patient as well who married person and no chance of going out to anyone else, and had an acute Epstein-Barr. And of course, in the younger time, there may be. So I'm seeing a lot of reactivations as well. So one question, for example, my wife developed some of the facial symptoms. The Epstein-Barr, we have seen that study where they said that Epstein-Barr can actually be reactivated because the memory cells on the COVID lives in the bone marrow, and sometimes when they're living there and they're proliferating, they can cause the other cells nearby with the cytokines to start proliferating as well, which then starts the EBV. So tell me, when do you suspect EBV? So let's say there's a long COVID patient. When do you feel that, hey, this may be EBV reactivation as well? And do you then get the labs?
So a couple of things, absolutely. So one thing is, if someone starts developing swollen lymph nodes cervically in their neck. So if someone starts developing lymph nodes in the neck, I think that's often very consistent with EBV. Joint pain, which is really interesting. I was mentioning before, swelling in the hands. Again, I had a case of acute reactive arthritis where a gentleman I treated had his knee was swollen, and it actually was related to acute Epstein-Barr virus. Typically affect joint. Muscle pain, fatigue is another one we see very consistent with that. Sometimes elevated liver function we can see related to as well. But I find really when the symptoms really match what we've known as chronic fatigue syndrome, that really, which I believe is also related in some ways to Epstein-Barr virus, that can also be the case. And again, I think anyone I see with long haul, I'll actually check titers to see. And probably the most accurate way is you can do DNA PCR as well to see if it is acute.
Got it.
Epstein-Barr virus.
Got it. So now you're looking at patients' blood pressure, you're looking at their heart rates, their pulse, walking, moving, sitting, standing, and then you are correcting them for fluids. How is your success? So let's say with this, tentatively, what percentage of patients feel better? And then what medications, if you would like to share, how do you manage?
So I think what interesting enough is they may not feel better all the way, but it leads to better functionality, right? I think when your fluid status is more normal, you can, I call it activities of daily living. You can go walk around now. Your exercise intolerance drops dramatically. And again, you can do a lot of the functions of daily living. The other things we look at, and again, I'll look at lab-wise, I'll measure cortisol levels. I'm curious to see if it's low cortisol or high cortisol. One that we didn't talk about that I've actually noticed more lately. So there's a genetic issue called MTHFR. Have you talked about that before in your show?
I do not know if I have, but I remember reading it.
So MTHFR is a really interesting gene that can be seen in about 30 to 40% of people. And what it affects is the body's ability to utilize folic acid by adding a methyl group. The reason why it's so interesting in long hauler is that methylated folic acid really is your lead way to develop production of serotonin, dopamine, norepinephrine. So actually I've found now my patients with that genetic, especially if they're homozygous for that gene, they have much more severe long haul symptoms. And probably the reasoning behind that is their ability to respond to stress. And also methylfolate affects the Krebs cycle or energy producing cycle in the cell is hampered dramatically.
So how do you manage them?
So what I'll do is a couple of things.
Berkowitz magic, the prescription is out here.
It's so funny. Everyone, like, it's so funny as I go through my explanation in my office, they're like, okay, so what are we treating with? I'm like, can I do my explanation first?
Yes, absolutely.
So one of the things is you want to look at really mechanisms. So the post-viral, which could be a combination, again, we know also the spike protein is an issue, right? The long lasting of the spike protein, as we've seen in mice models, we both read about, where COVID continues to cause inflammation way past the virus. The virus could be gone, and that presence of spike proteins can continue to cause inflammation. So I found in my practice the two most effective things for lowering that spike protein are ivermectin, IVM, and intravenous vitamin C. And
I want to dig deeper in the spike protein part. So Dr. Bruce Patterson's paper, Dr. Yu's paper about S1 pieces sitting in monocytes. Have you managed patients with that in your mind and then giving medicines that may help the monocyte with activation, or Maravirox or low dose naltrexone, or
low dose naltrexone I use a lot. So what's interesting about that, I was reading about that and I looked back at Lyme disease, and one of the drugs they're now using for Lyme disease, which is antabuse disulfiram, actually works on that same mechanism by impacting the monocytes and macrophages. I use a lot of low dose naltrexone. I really like that. And what I use it more commonly is in patients which have kind of a histamine intolerance, right? Where they have this chronic histamine aspect, and that leads to chronically high histamine levels and what we call mast cell activation. So mast cells are these inflammatory cells that tend to go out through the body, and especially in the gastrointestinal tract. And these kind of patients I see often have a lot of like allergy-like components, that congestion, they'll have digestive issues, and low-dose naltrexone really can be very effective to that by both blocking histamine receptors and also by blocking cytokine receptors as well, which is our pro-inflammatory cells.
Very interesting. How about statins? Have you used statins, or do you selectively use
I'm
them? Not
confused by
use them?
that, and here's where my confusion. We had this discussion before. My worry is, again, for two reasons. Number one, high doses statins can impact glucose and insulin. And number two is a lot of the patients I see already present with muscle fatigue and muscle issues. And my concern is adding statins could actually exacerbate that.
Very interesting points. So then tell me one more. So I'm going to ask you these drugs too.
It's okay, no problem.
So I have never used Miraviroc. Have you used Miraviroc?
No, I have not either. I have not used the inhibitor. And again, I know that in Dr. Patterson's protocol, he's looking at the specific cytokine responses and seeing that response. But what's interesting about cytokines, I think we have other drugs that I've used in my, we talked about vitamin C, IVM, and also low-dose naltrexone, which all impact cytokine levels.
Got it. So then tell me this. You are such a fascinating guest, and we have so much of the knowledge coming from you that I want you to be here and keep talking with us. So tell me this. You said that you look for cortisol levels as well. Do you then decide steroid therapy based on that, or do you give steroid therapy, or you do not give steroid therapy at all? What is your approach there?
I mean, the nuance for me is I feel I'm a little worried when someone has very high cortisol levels and the adrenals are already pumping out so hard is to increase, by adding a glucocorticoid or prednisone to make it worse. I tend to use it more commonly if someone has very low aldosterone levels or very low cortisol levels.
Got it.
I think those are the ones, I don't know what you see in practice, that I tend to think those individuals have the most benefit from adding steroids.
So I'll tell you mine, and that seems less refined compared to yours. I give low dose steroid therapy to everyone. So there is a difference. And thank you that you do a test first and you figure out who should.
But it's interesting you say that. And I've actually, even my treatment of acute COVID, and we discussed this before, I've actually, from your suggestions, thank you, I've actually been introducing steroids much earlier in the process. And I find, but not even at high doses, even like a Medrol dose pack, which starts at 24 milligrams and tapers down, I think there is tremendous benefit by introducing that much earlier in the process.
Excellent. Thank you very much. And the reason that I had was that eventually majority of our issues, diseases, poke the inflammation system, the immune system, and eventually there is inflammation. So at least if we start tapering down the inflammatory processes, then that would help hopefully unmask the actual pathology, or maybe would start curtailing the immune out of control behaviors. And I have seen great success with this. I have a question for you. So Bambi Secret, she's from UK, she's a cool bean. And many times, so this may be, I think, 1 or 2 in the morning when in UK. Can you have a skin allergy test that shows a moderate reaction to histamine, yet not have MCAS and have normal serum tryptase?
So I just had this question today. Thank you, Bambi. So I want to start with the serum tryptase. Serum tryptase is really interesting. Unless you're having an acute reaction, oftentimes that's going to be normal. You have to catch people in an acute reaction to the allergen to have a positive serum tryptase. With the mast cells, I think that's harder question to answer because we don't always make the diagnosis. The most common place I'll see mast cells is often on a biopsy done either by someone has an endoscopy, and they'll have an endoscopy and they'll have a biopsy of the gastric mucosa, part of the stomach. That's really the more common place that I'll see mast cells present. But based on histamine, I think you can still treat, if histamine levels are high, still treat as kind of mast cell syndrome.
That's very, very interesting. So just for the cool beans, for the audience here, steroids has been one part of the long COVID. Mast cell activation syndrome and the management of that is another. The macrophage activation syndrome and the management of that is another part of it. And then, of course, the Rantes and then Miraviroc or maybe even leronlimab at some point. So I'm going to ask you one more question. Macrophage activation syndrome, that is Dr. Marek's proposal. Have you used some of those as well? Therapies? I'm putting you on the spot. You can totally say
Which
I'm
ones
not
do you
responding to
which ones
this.
do you think the more the supplement active or more from?
For example, vitamin C and
Oh,
statins.
without a doubt. So vitamin C, omega-3, melatonin. I mean, to me, vitamin C is vitamin C. I should say my words,
Yeah.
but vitamin C is a key component. I find it's actually I'm going to take a step back. So it was really early. So when
Mm.
if we go back to March 2020, I saw all these cases of flu. Well, now probably turned out to be COVID. And oftentimes I'll use intravenous vitamin C to impact the flu. And what was interesting is these patients actually got better within 24 hours after high dose intravenous vitamin C. And these turned out to be COVID cases. I think vitamin C is so critical because it has so many impact, so many different pathways. It helps stabilize cortisol. It helps as an antimicrobial, right? It helps as an
An antioxidant.
anti-inflammatory.
Yeah.
It has a positive effect on the endothelial function of the blood vessels. So it more than almost any other drug out there, I think it does everything in a lot of ways. I think that's so critical. The other one that's really interesting, I think, also using fairly good doses of vitamin D is critical as well.
Yeah, I was going to ask you about that. So tell me this, for vitamin D or vitamin D, do you check the levels and then suggest for vitamin D, or do you feel that somebody who's in long COVID or is in COVID should get a little higher doses of vitamin D? And
So
how do you see the progress, the response of the
remember, I
patient?
practice in New York. Everyone wants their levels, right? So it's a difference. So we draw them anyway. But I really feel that you need to at least 5,000 IUs to really be effective. I think that's really key. I mean, there was some really interesting studies. I don't know if you saw that early on in Brazil where they used doses up to 100,000 IUs for 4 or 5 days to treat patients with COVID. So I think vitamin D is so interesting. And you know more mechanisms I do. I wonder if there is also a mechanism there where it competes with COVID for those receptors. Where actually can you actually displace it by doing higher doses of vitamin D?
That's a very
What do you
interesting.
think?
So what I know for vitamin D and the COVID is that instead of the work with the ACE2, more of the working inside, and it modulates a nuclear factor kappa B pathway, which is one of the pathway that SARS-CoV-2 uses. So because SARS-CoV-2 uses for pro-inflammatory behaviors and vitamin D helps modulate that downwards, vitamin D is sort of kind of stopping the virus to say, no, not that fast. Sure, you can do what you're doing, but I'm not going to let you be that fast about it. I think that really helps reduce the speed of damage, which allows the immune system to attack the virus. This is what so NFK beta is a known pathway. The remaining is my conjecture.
No, I think that's really critical. Again, if you start looking at there's now mortality studies coming out, which really shows the impact, probably of vitamin D more than almost anything else on
Absolutely.
our mortality, morbidity from COVID, SARS-2.
Yeah, so I had discussed a study from Iran where people with the vitamin D level greater than 40 nanogram per milliliter had, and in advanced age with comorbidities, their mortality rate was down to 1% or 0.6% of the folks who are in the hospital, compared to in the same hospital, non vitamin D good levels, their mortality rate was 6% or higher. And nowadays there are more studies as well. So vitamin D is actually proven.
And I
It
have
is
some colleagues in the ICU that will often give 10,000 IUs of vitamin D3, regardless of the levels upon admission to the ICU, where they'll use doses that are fairly high because of that purpose.
Got it. And there is a question from Stepping into Grace says, what about vitamin K and with vitamin D? So I know that I have always talked about vitamin D with vitamin K2 or MK7, with magnesium and calcium at different times. Keith, what is your approach? If you are asking someone to take vitamin D, what else
I
do you?
think obviously if you use vitamin D long term, you need vitamin K. vitamin K is so critical for maintaining endothelial function. So it's so important for the blood vessels. And actually, if you read the studies on heart disease, which is so fascinating, the one thing that's shown more than any other supplement to kind of lead to repair of blood vessels and improvement in heart disease is actually vitamin K, and especially vitamin K2.
Absolutely. Oh, so just simple vitamin K, not K2.
I use K2. K2 I would use.
I use K2 as well because K2 would help mobilize the calcium from incorrect places where it can go and start depositing.
And you know what's interesting? So it leads us to an interesting other thought. If you notice that, look what people are deficient. They're deficient in a lot of the fat-soluble vitamins, vitamin A, vitamin D, vitamin E, and vitamin K. And I think that's getting worse and worse. And I think the digestive aspect of disease, and we've talked before how COVID also impacts the gut microbiome, probably leads to people to also have these deficiencies, which are kind of exacerbated by long haul symptoms.
Absolutely. I totally agree with that. Although it is funny for me sometimes to see that folks have been, and I'm a small fish. I mean, they call me that I peddle supplements. I don't get any benefit of peddling supplements. But I'm seeing that they even criticize Paul Manick's work and vitamin C there, and they say he's still peddling vitamin C. If there is a deficiency of these normal, important supplements, there is a serious risk to immune system's normal function. Why do you feel that we have so much aggression against the supplements?
I think the number one thing is they have bad salespeople to begin with. So we need better salespeople for supplements. Number two is I think that what happened is, I think if everyone thinks of RDA as the amounts of supplement levels you need, I always joke RDA is like the minimum wage. It doesn't get you anything. And what's interesting is I think it's just not taught to us. The third reason, what's really important. I mean, I've learned in talking with Dr. Merrick, what's interesting, we talked about steroids and the importance of steroids and how it show clearly now, I don't think anyone would argue the importance of steroids in treating very sick COVID SARS-2 patients, right? I think there's no argument at this point. But people don't realize steroids go through a vitamin C pathway. So adding vitamin C to steroids supercharges the steroids. So they work so much more effectively. And one of my colleagues did an early study at his hospital, and he found all the patients he admitted to for COVID, 85% of them had low vitamin C levels. And to me, vitamin C is so critical because as humans, we don't make it.
Yeah.
We have to ingest it because we don't make it as well.
So Debbie says, how much K2? And Debbie, I'm going to give my answer first, and then we'll ask Dr. Berkowitz as well. I have done a video, which is some shameless plug of my own video. I have done a video talking about the amount of vitamin K2 and magnesium, calcium with vitamin D. So, Keith.
Well, you were going to go first, I thought.
I usually just ask for a daily RDA for K2.
You know, that's a hard question a little bit because depending on the form, the doses are different. And I think that's where the challenge is, right? So some forms of pure K2 use 50 micrograms, 100 micrograms, but it depends on the form. But typical, that's what I'll use, somewhere around that range.
Got it. And tell me, do you use quercetin, zinc, any such things for long COVID?
Yes. So quercetin I use. The only caveat, and one thing I have seen, I don't know if you've seen it, I'm definitely seeing an uptick of autoimmune thyroid. So I'm seeing an uptick of people having positive antibodies to thyroid gland, typically thyroid peroxidase antibody. So in that group, I'll use lower doses of quercetin. I'll use probably 250 milligrams, where in another group, I'll use up to 500 milligrams. I often like using quercetin with bromelain together, as bromelain has a little bit of an anti-inflammatory effect as well. But quercetin I've used for years because it's well known to, for me, it's studies on things like HIV has such a potent antiviral effect.
Got it. Thank you very much.
And zinc is critical. So zinc, it's interesting. Early studies, like they talked about hydroxychloroquine, they talked about Zithromax using anti-inflammatories. A lot of the medications we use today work through a zinc pathway. So zinc is so critical to be used as well too, and has, especially for RNA viruses like SARS-CoV-2, it's a critical component to fighting that.
So tell me this, if you receive a patient who has chest pains, fatigue, tiredness, but does not have POTS, does not have tachycardia, does not have neurological symptoms, just the tiredness, how do you manage them? How do you support them?
So the chest pains is really interesting. I asked two different questions. And actually, by the way, I had COVID, and this is one of the symptoms I had. I had this shortness of breath, and that triggered chest pains. What was interesting about the shortness of breath, happened with a normal pulse oximeter. So my oxygen levels are normal. It really felt that my lungs were covered with saran wrap. That's how I would describe it the best. And what's interesting were the chest pains really a component of that, where the body wasn't getting enough oxygen, even exchange rather than decreased oxygen. And what's interesting, that I've used IVM very effectively. And that's where steroids also plays a role as well.
Very interesting. And how about fatigue? If somebody just comes over and says, I'm just tired, I'm sleepy, I'm tired, I'm fatigued, what do you do?
That's where I think intravenous fluids has a role. Also, intravenous vitamin C is actually really effective as well in that group. Because again, you're trying to replete what's missing. What's also interesting is, I don't know if you've seen this, oftentimes they'll have low iron levels. One of the factors of any acute illness, and people often forget, is acute infections often deplete iron stores. And so you'll see very low iron stores that haven't replicated. So that can also lead to an anemia and iron deficiency, which could also lead to fatigue as well.
Got it. And please don't mind when I keep looking on this side. These
It's
are
okay.
the comments over here. So I'm not ignoring you. I'm looking at the comments. Cool means if you have a question, just put QQQ or question mark so I can catch the questions.
Remember, I'm in New York City. We don't get insulted.
So Ellie says, can Dr. Berkowitz talk about quercetin and antihistamine possible interaction and how antihistamine dose could be adjusted?
So actually, quercetin is known as a natural antihistamine, interesting enough. So I would probably would not use both at the same time. I would choose one or the other. Or if you're going to use both at the same time, I would use, again, a lower dose of quercetin, often 250 milligrams, as opposed to
how about melatonin? Milligrams. Sorry.
Melatonin is great. So melatonin is so interesting. You know what I learned about melatonin? You want to hear something funny? So I was reading this really interesting article. It was from Japan. Melatonin, one is the key components of IVF treatment, fertilization treatment, in vitro fertilization, that melatonin made a big difference. And you know why? It lowered cortisol. And by lowering cortisol, women's progesterone levels came up. So I was like, oh, wow, this is interesting. So it's interesting. So it has a cortisol effect, but it also seems to have a really powerful effect on innate immunity. I don't know if you've talked about this before. We really go through two immunity processes. There's innate immunity, which is the initial immunity, which probably, would you say that's more histamine generated?
Absolutely. And try us. Yeah. The cool beans are actually very well versed with the innate and adaptive arm.
So that's the histamine based. And then the second one, which is acquired immunity, which happens when we have an antigen to antibody response, which can take 2 to 3 weeks. So what's interesting about melatonin, I think I read this in Nature, I don't know if you saw that too, about its power in actually helping with innate immunity, the initial immune response for the body.
And there is another very important thing for melatonin that I discussed in the past as well. And that is that at one point, our immune system cells start becoming exhausted with the COVID, and their mitochondrial function for ATP production becomes disrupted because of phosphorylation of some of the enzymes. And one unneeded side effect is that the pro-inflammatory markers start getting produced. So when melatonin is given, it goes into mitochondria, corrects the ATP production, and a side consequence is to balance out the pro-inflammatory markers. And so as soon as the cell starts having correct markers, the cell starts defending itself and is able to then continue from there.
So it's interesting. Would you say then in that same that you prevent, I guess I call it anaerobic respiration, right? Where you start building lactic acid.
Yes, it does.
So that's interesting. So I'm going to ask you a question, if we can turn it for a second. So one thing I've always really interested in is, and we talk a lot about Krebs cycle, right? Which is the mitochondrial cycle. And using things like coenzyme Q10, NADH, which are important cofactors in that process. Again, we talked about fatigue before. Is that another aspect of fatigue that could be addressed a different way, where we can actually help ATP production by enhancing the Krebs cycle?
So for all of my folks, for my patients, I always add CoQ10 as well, because what happens is as soon as the electron transport chain is running in overdrive, it is producing a lot of reactive oxygen species as well, and one of them is with this enzyme. So the raw start escaping, and this enzyme's function starts becoming disrupted. So as soon as you give CoQ10, the electron transport chain's function becomes better, and as soon as that becomes better, the cell starts stabilizing.
I use an NADH. A lot of people now, Joe Rogan, when he was recovering from COVID, he did NADH. I think it's also become very popular as an intravenous medication. Have you had experience using that as well in that process?
I give oral NADH always. So CoQ10, NADH, turmeric, vitamin C, vitamin D, melatonin are my standard part of my management protocol.
So it's so interesting. So again, it's interesting. So really treating long haul is really like we treat a lot of other disorders, right? We're trying to stabilize the blood sugar. We're trying to stabilize the gut microbiome. We're trying to make the Krebs cycle work better. I mean, it's really getting the body to work in its optimal way.
That's it. That's it. That is the statement, to get the body back towards a normal, balanced behavior, and things start becoming okay.
What about probiotics? Have you used probiotics as well?
That is one thing that I have not used as separate supplements. I give yogurt, and I say take natural yogurt, which is sort of a good biotic as well, but haven't given probiotics.
So I have a theory, and I don't know if it's true. And so it's really interesting. There's a strain that I've learned to use called Saccharomyces Bilardi. And what's interesting about that strain, it's often the strain we use in people when they take antibiotics and to repair the gut microbiome. And I've heard from other anecdotal data from two gastroenterologists I know, they talk about another strain that's depleted called Bifidobacterium. So I believe that as part of repair and rebuilding, it's important to really add back those probiotics. And again, for that reason alone, but also to improve production of neurotransmitters. So again, we know a lot of our neurotransmitters, dopamine, norepinephrine, serotonin, are produced within that gut microbiome. And you probably have talked about fluvoximine, right, and serotonin. So I think that's as important a component to repair and rebuilding in my protocol that I use a lot as well. And I'll use also L-glutamine in that same process as well.
That's very interesting. That's very interesting. So I'm gonna I know that it is 1 hour and it is late. You are on the East Coast. I'm sitting here on the West Coast.
I'm having fun though.
So I have one set of questions about the tinnitus and the neurological symptoms. I want to go there in a second. Here is a question. Stepping into Grace says, is thyroid autoimmune part of long COVID? I was diagnosed after COVID. I didn't take quercetin at that time.
And the answer is yes. And here's what's interesting. So I was trying to figure out if it's old or new. And what I often do is after I have positive antibodies, I'll do a thyroid ultrasound. And what I'm finding interesting, the thyroid ultrasounds are normal. So to me, probably means that it's a newly acquired autoimmunity. Yes, I have about 10 cases of that where they have normal thyroid function, but they'll have positive thyroid antibodies, especially thyroid peroxidase. I'm seeing a lot of.
Got it. So before, yes, it was. So before I go into the neurological symptoms, let me ask you one more question. When prescribing ivermectin, have you gotten, so again, you can skip any question and say, I'm not answering this one. Have you gotten any pressure, pushback, threats, called names, any agencies coming after you? Keith, did I lose you?
I think when you said ivermectin, the internet went down.
Yeah, sorry. So with the usage of ivermectin, with your prescription of ivermectin, have you gotten any pushback, any pressure?
It's funny. The most pushback I get with patients because I can't find a pharmacy to prescribe it. That's been the biggest pushback I get. A little bit from pharmacists. It is what's interesting. So now I'm using the lung for long haul COVID. So I often say it's for Epstein-Barr virus. Right? So that is not for COVID.
It is actually EBV reactivation as well. And there is studies to show that there is EBV reactivation.
Yeah, so now I've used the reasoning. I now say it's EBV.
Hmm.
They don't know what to say to me. The pharmacist, on the other hand, will say to me, okay, I think that's allowed. That's not on the list. Because they only see COVID. So COVID is now gone. It's all Epstein-Barr virus.
Got it. And it's a sad matter of affairs that a doctor cannot do the doctoring part. So Alive and Heals says, how can people, and she's a great cool bean, how can people get this great doctor for treatments? So here I have brought up your page. Is this a correct
yes, that's
website
correct.
to show?
It needs a better picture though, but everything else is good.
This picture is awesome. So Center for Balanced Health, 425 Madison Avenue, New York, New York. And here is the phone number. So please, if you are looking to connect with Dr. Berkowitz, and so no commission on my end. What I'll do is this, just very quickly, I'll shamelessly plug Dr. Bean as well. So if you wanted to buy medical lectures, here is drbean.com. Okay, so I'm going to come.
Can I tell you the most fun I've had recently is we did a lecture together, and next time you have to bring out your whiteboard. I mean, it is so critical when you use the whiteboard. Your drawings are phenomenal.
So much fun. Did you enjoy it when that was an
without a doubt
talk?
And you know what's interesting? I am such a bad artist. So bringing someone who has such a great skill, it made me look so good, by the way.
That is awesome. I loved it. I still remember that talk that you were presenting the concepts and saying, here is what I'm doing and here is the medicine, and I'm drawing and saying, this is how this happens. That was fun time. And if people want to watch that video, it is on FLCCC's channel and site. Okay, so now switching to the neurological symptoms. Of course, the most difficult ones are brain fog and the tinnitus.
Yeah, I think it's the most difficult to treat. I mean, I really find if you look at the people that are suffering the worst, it's really from those issues by far. And what's interesting, so I would do it too. So early on, we talked about glucose, and I have a little theory. And I seen another symptom is what I saw as a symptom is hyperinsulinemia, where patients actually post long haul COVID had high insulin levels. So there was pancreas disruption. And when they end up with low blood sugar, I wonder if some of the components of tinnitus is actually related to low blood sugar. When I did my training early on, that's one of the things I saw is people often had low blood sugar, and that affected nerve function and led to tinnitus. And the reason why I also thought that, if you think about how tinnitus presents itself, it's really in a quiet situation, right? Where your body's in a relaxed state. And symptoms typically in a relaxed state is when cortisol drops down and also blood glucose levels drop as well. So I do think that there is some, and I don't know the connection exactly, maybe it's something we can look more into, is the relationship with long haul COVID and blood glucose regulation.
That's very interesting. So when you are managing tinnitus, number one, what is your success rate and what is your specific approach towards tinnitus?
I was hoping it was
we're going to get all of your secrets today.
I was hoping you would ask the question around what was my method, and then what's my. I would tell you it's the hardest thing to treat by far. I don't know if you've seen the same thing, and it takes the longest to recover. And oftentimes it'll take multiple rounds. Well, I'll use, and often the tinnitus is also accompanied with ear pressure. Do you see that as well? Ear pressure oftentimes.
I have 4 things that I've used, and they work. Low-dose steroid with fluvoxamine. In one case, fluvoxamine actually increased the tinnitus, so that means it doesn't work in all cases. Low-dose steroid, fluvoxamine, low-dose naltrexone, and what was the 4th one? I forgot. There is one more. It will come to me.
IVM?
No. There is one
low dose. So we've talked about this before. I will often use low-dose IVM with together with low-dose steroids. But there's another treatment that's really interesting. It's an old treatment. So I don't know if you ever looked at when people have hearing loss. So one of the traditional treatments for hearing loss is bioflavonoids. Citrus bioflavonoids have often been used. And I find actually vitamin C also helps with tinnitus dramatically. The one disadvantage to intravenous vitamin C is I always tell my patients to bring food because it can lower your glucose levels. But I find probably my most effective treatment is intravenous vitamin C.
Very interesting. And I remembered mine. So the statins is the fourth. This is the combination. Steroid, fluvoxamine, low dose naltrexone with statin. So maybe all of them work together and that is fine, or maybe some of them and I have become
So
used
I
to
mean,
it.
so your theory is then again it's an inflammatory process, right? Then you're really thinking that this is inflammatory. You know, it's interesting because I've actually done CAT scans of the sinuses because I was worried about congestion, and they're clear. People have severe congestion without physical evidence of congestion. It's really kind of fascinating, I think.
For me, what is important was that if someone's vestibulocochlear nerve is swollen or inflamed, and it is stuck in the cochlear canal or the the little bony canals that it traverse, if it is inflamed and it stays stuck in there for a longer period of time, it would become damaged. So I try to keep the inflammation low, and maybe that allows whatever the rest of the pathology is to recover. And then because there is no inflammation, it helps reduce the chance of more permanent tinnitus. Maybe this is a fluke because so far I have not actually found what is the right pathology caused by COVID which causes tinnitus. I do not know the pathology.
I believe it's blood sugar because when I treat my regular tinnitus, that's what always been. And vitamin C, there is a lot of literature on that. The other thing I'll use is a nasal antihistamine spray. I'll often use as well to see if that has an effect more direct on that, right, as opposed to taking more systemic antihistamines like a low-dose naltrexone. I find that sometimes is effective as well. But typically, I think the steroids, of all the things I use, is probably the most effective in a low dose. And we've discussed this before. And then even with IVM, I found that actually sometimes using a lower dose for a longer period of time seems to be more effective than my original treatment, which was, a higher dose, like for IVM 0.2 mg per kilogram for 4 or 5 days. Now I may do 3 to 6 milligrams for 2 to 4 weeks. And again, a lower dose of steroids may be 5 to 10 milligrams a day for a longer period of time as well.
Very interesting. So 3 to 6 milligram, that is really, really low dose of IVM.
I wonder if the more chronic issues, and especially if people have had these symptoms for a longer period of time, require a slower approach and a less aggressive approach.
That's a very, very interesting idea. I've never done that. So tell me this then, if we move from tinnitus, the brain fog and the concentration issues, how do you manage them?
So brain fog and concentration issues, I think that's where low-dose steroids can have an effect. Low-dose naltrexone is really effective. Low-dose IVM is effective. Intravenous vitamin C has an effect. Again, if it's true brain fog versus lightheadedness, I think sometimes those are often confused. If it is lightheadedness, then intravenous fluids and even adding salt to the diet does have an effect as well too. I haven't had much experience. I don't use the SSRIs very much, like Fluvoximine, but I suspect serotonin may have an impact as well too.
Fluvoxamine has done very good job. Statins have done good job. IVM has done good job. Low dose steroid and low dose naltrexone in some cases is like a magic.
I have a long experience using it. I've used it for years for autoimmune disease. So I've been using it for a long time. A lot of my ulcerative colitis, Crohn's patients, rheumatoid arthritis, I've been using that for a long, long time as part of treatment.
Got it. Very good. So thank you very much for your time. I'm going to look at a couple of more questions here, and then we don't actually want to let you go, but I think nobody's going to watch it if it goes above 1 hour, and it is. So
it's not like, who is that? Brett Weinstein? It's like 4 hours.
Yes. Well, relatively better, huh? So there's a question. This is actually a very common one. I suffer very bad headache. Please help. So again, no medical advice. We cannot directly provide any.
So I think what I always think of, again, the word headache is so meaning so many different things. I think what's really important is to figure out a couple things. Is the headache first thing in the morning? Because I think, is it a migraine type headache, right? Is very different. Is it more of a tension type that happens as the day progresses along? That is a little bit different because the etiologies of what causing it, or But again, could it be inflammatory? And we can have this whole other discussion about blood sugar regulation. I was watching one of your other videos before I came on diabetes the other day you had. So I think blood sugar regulation has a big deal. What I've used traditionally for headaches, which is really interesting, is I often will use magnesium and B12 in combination, which really is very effective. The B12 often lessens the neurological aspect of the headache, where the magnesium opens up blood flow. Because could the headache also be muscular, right? A lot of times neck pain or muscle spasm can cause a headache as well. I think the key component is really flushing out what's causing the headache and when it's happening, what part of the brain it's happening, and why it's happening. And the last comment on that, and I don't know if you saw this too, Mobeen, one of the things what's interesting about long haul syndrome, it seems to attack people's weaknesses. So example, if someone had bad infectious mono or Epstein-Barr when they're younger, they tend to get a worse case. If someone had headaches like migraines, they tend to get a recurrence of that. You know, things that they suffer from, they had chest pains before, they tend to get a recurrence. It's really fascinating syndrome where it's able to pick out our weaknesses and amplify them tremendously.
It pokes them. I think maybe I'm wrong, but I think what it does is, as it activates the immune system, then whatever immune memory cells were present, if they, and for the healthcare workers who are going to say, and medical students who are going to say, well, this is not possible. Memory cell becomes reactivated when the antigen is present. So it cannot just be reactivated by itself. But we have an example of EBV that sits in the B cells and can help them reactivate. So it is possible that there is some antigen presence, so there is something, and the inflammatory process pokes some of these memory cells or inflammatory cells to become active again, and they start producing.
I had an interesting early case of that where someone had a history of head trauma, for example, and the head trauma was very specific for the temporal region on the left side. And what's interesting, post-COVID, her symptoms really were much like that. That same kind of area really was affected, and where her focus or concentration, a lot of things associated with that were definitely affected. And I think you're right. I think there is previous damage that gets reactivated because there's probably already existing inflammation there, and that inflammation gets ramped up to another level.
Yeah, I think that is, again, so here is a question. Augie says, long-acting or regular vitamin C?
Can I add a third comment? I like liposomal vitamin C, but
somebody had asked this comment that why does FLCCC not use or recommend liposomal compared to other? So maybe you can answer that as well.
It's whether I was on that call or not, but but liposomal I'll use because the absorption is so much better. But it's interesting. So one of the theories behind, and this is, you know, in Dr. Merrick's early research, they were giving vitamin C intravenously 4 times a day because of its such a short half-life. I do it a little differently. I'll do a higher dose one time, and I do have good effects with that. But I think vitamin C, probably in most cases, has to be at least prescribed twice a day because it is short acting. And again, humans, you know, we're unable to make it on ourselves. And I think we really utilize a lot very quickly. Have you ever seen this, Mobeen? I had cases years ago where I had people who had infections, and this was typical urinary infections, where they wouldn't clear. And one of the components I would often see is very, very low vitamin C levels, where that really impacted the body's ability to clear infection.
I have not seen that. I have not observed. It's not that it doesn't happen. I just have not observed it. What a great insight. So I'm going to keep an eye on it.
And I may be one of the few people that draw levels. I don't know if people often draw serum levels of vitamin C.
That's a very interesting point. This is why I don't want you to go. I want you to just keep talking. So Kelly says, what are your thoughts on using Floccitane instead of Fluvoximine?
Oh, I'm going to have you answer that one.
So I know that there is a similarity, except that the sigma 1 part may not be as strong. So people have used Floccitane instead of Fluvoximine.
You know what's so interesting on that is even in the integrative world, we'll use tryptophan and 5-HTP because it does have some serotonin. And I think you're right when you said fluvoxamine has that greatest sigma 1 response. But I think serotonin as a whole has a neuromodulating effect on any.
Absolutely. That is true. And that is common for both of them. Patty Zig says, I've read so much about deficiency in B12 causing brain fog. My ex had it and was Rx, high potency B complex, and he said was like night and day.
I would say interesting. So early on, I was talking about the MTHFR gene, and I see that kind of component with that, where using a methylated form of B12 along with methylfolate is very effective. And it's really interesting. If you read a lot of the psychiatric literature, they now talk about using folic acid, especially in a methylated or a methylated B12, as a treatment for depression and anxiety. So it definitely probably has a neurotransmitter, impact. One theory behind brain fog is I think the inflammation in the brain impacts glucose transport. And I think there is something to that. And I'm not sure, how that mechanism is, but I do think there's something along with that. And B12 does modulate that.
Got it. Thank you very much. So Margaret McKinnon says, a wonderful program tonight. This will make a great resource of ideas for many things. I actually agree that you have given us so many directions to think about. And this is what I dislike about the protocols, because protocols confine us in one list almost, or maybe a chart and a decision-making chart. And that's about it. There is no flexibility to go think and do some creative work. So thank you. I
always had a funny comment. One of my professors, I'll end with this comment. So he was talking about clinical studies, and this is I always find interesting. So he says, if you have 10 patients in a clinical study, if you're at patient number 10, you don't really care what happened to patient 1 through 9. You care what happened to patient 10. So again, that whatever happens in that individual case, and again, I think the lesson learned is always one size does not fit all, that everyone has to be treated as individual, because outcomes, there's so many confounding variables to the human body that everyone has to be treated individually to have successful outcomes.
Totally agreed. And I saw a lot of comments here to say that we should have Dr. Berkowitz come in here on more regular basis. So before you leave, promise us that you can come on more regular basis.
Okay, it sounds in person, or I have to. If you were in a warmer climate, I would definitely come in person.
Absolutely, or I will fly over. Let this pandemic, cool down a little bit, and then I will fly over and we'll do an in-person chat as well.
I think it's so interesting, and I'll end with this. My training's always been in integrated medicine, and what I really am so excited about, what we've learned in COVID, it's really that integration that's happened, where we're using both natural substances, natural vitamins, combined with medications to get the best possible protocol. Again, we don't always want to use protocol, but to put that together, and that has always been my dream. And that was actually Dr. Atkins' dream. So he must be listening from somewhere, saying, oh my God, I've talked about all those supplements. You're finally using them.
Excellent. So thank you so much. Thank you for the insights. Thank you for a rich discussion, which included many, many aspects of long COVID and then HIV's practices and learnings from there as well, and your work with Dr. Atkins and vitamin C and FLCCC. And I think that it is fair to say that if we wanted, we could continue going for 6-7 hours just in this session and keep talking about more things.
If you agree to see my patients tomorrow morning, we have a deal.
Thank you very much. I think they are better off with you. So Dr. Berkowitz, thank you so much.
And thank you so much for having me. And okay, have a nice evening. Be safe.
No, so we are here. I was just going to show your site once again.
Most importantly, before I come on next time, I have to come up with a nickname. Right? I mean, I think that's important.
So your cool bean name has to be selected.
Okay, I will work on that before I come on next time.
So for the cool beans here, please suggest a cool bean name for Dr. Berkowitz. And I wanted to show Keith's site over here. So once again, for anyone who is interested, this is the site centerforbalancedhealth.com. and 425 Madison Avenue, New York, 10017. And here is the phone number, 212-459-1700. I have no commercial.
And actually, I do post some studies and stuff. I do a lot of stuff on Instagram. If you want to follow me on Instagram, I will post a lot of information about my personal interest is what I call reactive hypoglycemia and blood sugar dysregulation.
Absolutely. So how do they find you on Instagram? Here?
Dr. Keith Berkowitz. Is that it? Oh my God. There we go.
There we are. Very good. So here is complete way to reach to Dr. Keith Berkowitz. Once again, thank you very much.
Oh, thank
And
you so
Cool
much for
Beans-
having me. I hope you have a nice evening.
So Cool Beans, I think you enjoyed this treat of Dr. Berkowitz's discussion, his time. I would continue to request him to come back and discuss more with us. Thank you very much for being with us. Please
Thank you so
like,
much.
subscribe, and share. And Keith, thank you very much for being
Oh,
with
with
us.
pleasure. Have a nice evening and everyone be safe. Thank you.